I'm going to ask Dr. Abu-Rus to come back on, and we're going to have a mini panel for about 15 minutes here. We're going to tap into some of the discussion points that you both highlighted. So radiation oncology points for patients with unresectable stage 4 disease, and then these newer therapies, ADCs, bispecifics. So I will kind of do a round robin and go back and forth between Dr. Abu-Rus and Dr. Reichman. Dr. Abu-Rus, you talked a lot about these mechanisms of action, how these drugs are working, how they're different than just standard chemotherapy, different than immunotherapy. So I really like how you said chemo on a stick, right? One of the hardest things I think is when patients come to clinic and they're trying to understand the drug that they're going to be on. Tell us a little bit more about how you actually explain it in clinic, like maybe one or two sentences, their caregivers there, their families there. But what does an ADC boil down into like one or two sentences?
I can't claim any credit for the chemo on a stick. It was Joshua Subari's description. But when I describe it in clinic, I always say that we're trying to use targeted chemotherapy because at the end of the day, it's chemotherapy, but it's delivered in a targeted fashion. And I try to explain it that what we're trying to target is a very important protein or molecule to the cancer mechanism that, the science show that it's more expressed on the cancer cells rather than the normal cells. And then I build on that saying that there will still be some expression on the normal cell, and that can result in the side effects. And then, as you all know, each ADC has its own side effect profile. So then I talk about that and try to explain it as much as possible.
That's perfect. And Dr. Mira Patel is going to be coming on a little bit later, medical oncologist, talking about biomarkers and how we really try to personalize treatment for patients with lung cancer. You hinted a little bit about finding a target and using this targeted chemotherapy to kind of direct and fight the cancer in that way. Do patients need special testing then to see if an ADC will work for them?
It depends on the ADC and the approval, right? The science, shows that yes, the more of that target that the cancer cell that you have, the more benefit that you will gain. But unfortunately, that's not always how, this translates into human studies, right? In the lab or the cell cultures, yeah, that showed, but in human studies, it does not translate all the way. So when we're talking about, for example, telisotuzumab vedotin, so that was, or even TDXD, the approvals for these two ADCs in in lung cancer or in cancer in general for TDXD depends on the level of HER2 in TDXD or MET in lung cancer. So if the patient has 3 plus or more of that protein on their cancer cells, then they qualify for that protein. So for these two examples, yes, you have to test for the target in order to see if your patient qualifies for that ADC.
Yeah, that's really helpful. So it sounds like there's some drugs where you have to look and
Yes.
see if there's a lot of protein being expressed by the tumor so that it can go after it. And then
Yep.
there's some drugs where you don't need to test. So it really just depends. And the testing is different than next generation sequencing or gene testing, right? So there's protein testing, there's gene testing, there's a lot of different tests.